For today, the Canadian Foundation of Healthcare Improvement has supported us, IBM has supported us, PwC, 3M, and then of course the facility from St. Michael's Hospital. Thanks. For those of you who are attending your first breakfast with the Chiefs, there will be time for Q&A after the presentation. There will be some handheld mics, so just raise your arm and we'll come out and give you the mic. And I would now like to also remind you that Andre's book is available for sale. You can get it after the event out front, and I'm sure if you smile nicely, Andre will sign the book for you. And without further delay, André Picard and Andreas Laupacis.
Thanks, everybody. Delighted to be here. So the format is Andre and I are going to have a conversation for about 25 to 30 minutes, and then we'll open it up to questions to you folks. I don't think Andre needs any introduction to this audience. You're here because of him. I think probably most of us would think sort of Canada's public health and healthcare journalist. So, Andre, thanks for coming.
Thanks.
Maybe just start by, you've been with the Globe for 30 years. You were born in North Bay. You did your journalism at Ryerson. What got you into health reporting or public health reporting?
I did my journalism at Carleton.
Oh, I thought it was right.
Otherwise correct.
Okay, sorry.
I think I kind of stumbled into it. So like most newcomers to cub reporters, I started at the Globe as a general assignment. Started there as a summer student, doing a little bit of everything. But this was at the time that AIDS was just entering the mainstream, the mid-'80s. And because AIDS had been a big issue on university campuses where I worked in student papers for a few years. So I kind of naturally gravitated to that, and it was helped by the fact that our medical reporter at the time was not interested in AIDS. Not because she was evil or anything, but the way health reporting was done at the time was you reported what was in medical journals, you talked to eminent scientists and doctors, and that was that. And I still remember to this day her saying very clearly, like, why would you talk to patients? What do they know? They don't know anything. And that was really the attitude in healthcare and in journalism at the time. And AIDS has sort of been the backdrop to my entire career. And AIDS really changed journalism as much as it changed healthcare, as much as it changed politics. It was really a dramatic illness in many, many ways across society and around the world.
How did it change journalism?
Well, it made us pay attention to people, for one thing. And the breast cancer movement rode on the waves of AIDS, a very similar impact, a probably bigger impact in the long term. So I think it made us pay attention to that. It made us pay attention to things like the fact that, an illness is just not, it doesn't just affect the body, it affects society, it affects human rights, etc. It really changed our attitude towards drugs. Men marching in the streets demanding access to drugs, that was unthinkable. Drugs were a gift from the gods. And
so maybe actually I'll sort of jump to one of the questions I was going to ask before. In the intro to the book, you actually talk about a patient that was at St. Michael's with HIV, who you felt wasn't sort of, I think, given the care and respect that he deserved, and you talk about that story. And I was wondering if you'd talk a bit about how you as a journalist and how we should balance the power of stories with what can sometimes be the relatively bland and boring world of evidence. Do you want to talk about that a bit?
Yeah, so let me talk a bit about the story. I don't want to scoop people who haven't read the book yet.
Sorry?
So the whole story was when I was a young reporter at the Globe, and you get calls into the newsroom about things. And this was a call from someone saying that my partner's in St. Mike's Hospital, he's being treated horribly. You should go see him. So I did. And this was a man a gay man. At the time, people were not openly gay, so we were not to say who he was. And he was in the hospital for something, actually, he didn't have HIV, it turned out in the end, unrelated condition, but people knew he was gay, so they put a sign over his bed, a big pink sign, oddly enough, that said, "Caution, dangerous fluids." And they wouldn't bring food into his room, they put his food tray trays at the door, they're changing his bed. And it was just, St. Mike's was no different than anywhere else at the time. There was real fear, hysteria about AIDS. But this guy was a professional and he didn't take this, right? And I went in and I shook his hand and I remember he burst into tears and he said, "You're the first person who's touched me in 3 days." And I was like, and that story always remained with me. The power of just human contact is so much more important than medicine. And then the next day he published this very small story, and St. Mike's immediately went in there, cleaned up his room, issued an apology, and there was, the other part of the story was, wow, that's the power of journalism. In the days before the internet, people actually read the paper in the morning and read that, right? And to its credit, I think St. Mike's learned from that, and I think are one of the leading AIDS hospitals in the world. So I didn't want to be too critical of the hospital, but it was an example of the time. So to your larger question, I think it's really important to bring stories to life with people. If you read newspapers, and we love anecdotes. To me, the key is getting an appropriate anecdote. So I think we often, these days when we're in a rush to do everything, we just sort of tell patient stories willy-nilly, and they're not necessarily appropriate. And I think that's wrong, but I think you have to illustrate them to make the stories come to life. And I think a lot of researchers are learning from that too. You do a great job at Healthy Debate of telling those patient stories and clinician stories. And that's what people remember. That's what impacts policy more than the dry New England Journal of Medicine articles are important, but you're never going to convince anybody with statistics. I've learned that over the years. You can convince them with real people's stories. Now, the downside is I think we put too much credence to just a sad story. So I'm often bothered by the stories we do in my paper and others about so-and-so doesn't have access to this miracle drug. Those are really heart-wrenching stories, but what's missing in those stories is they're often not miracles. They're overpriced, oversold, overhyped stuff, and we're not helping the cause by telling this person's story. Even though it's a compelling anecdote, it's not necessarily fair. And it misses the context of, well, if we pay $1 million for this drug, what are we not going to pay for? And those are the tough policy issues, and those are much more difficult to write and much more difficult to illustrate, unfortunately.
I think from a personal view, the kind of, if you will, the story that has sort of brought to light this kind of challenge between some patients' views and actual evidence. And you've actually written about it, and I think you've actually written an academic paper about it, is that whole Zamboni procedure, where, very compelling story of Dr. Zamboni, who treats his own wife with multiple sclerosis, patients on the internet saying, they've been cured, scientists being, I think rightly, skeptical, but somehow not being able to get their message across, at least in my view, as effectively as they might. Are there some lessons to be learned from that whole saga?
Yeah, I think there's a lot to be learned from the CCSVI or Zamboni syndrome story. So I was involved in that very first story, and I still get flack about it to this day. And I always say that I wouldn't do anything differently given the information we had at the time. And that's important. To me, journalism is very much, or health journalism, very much like science in that it's self-correcting over time. So was that story overhyped? Yes. But, Zamboni did all the right things. He published in a peer-reviewed journal. It looked good. He had good anecdote. And the most difficult part of that story is that the doctors who had doubts about it wouldn't speak publicly. So I did that story, Avis Favreau and I at CTV. We used to be part of the same company back then, so we did stories together. And we worked really hard to do a balanced story. And we actually talked to 6 experts in the field who thought they had real doubts about it. But they wouldn't go on the record because I remember what I was saying. My patients would be pissed off at me for crushing their hopes, right? Now, eventually they came out and they were very critical of the media, without mentioning that they wouldn't speak out earlier, and that's fine. That's part of that goes with the territory. But sometimes it's difficult to do a balanced story. But I think we, in the end, did that story well in that we corrected it, and I think got a factual version of what it is that it looked hopeful, and it turned out to be not so much, as many things do.
So the one I think fairly personal question I had was around actually primary care, which I think most people would say is a really crucial part of any healthcare system. So just kind of curious where you live in Montreal, where you get your primary care and what you think of it. And your mom, when she was alive, where did she get her primary care and what do you think of it? And then the second part of the question is, if you could go anywhere in the world right now to have your primary care, where would it be?
I've got my medical records right here. And it's funny, people do send me their medical records now, I'm always shocked.
Oh, really? Wow.
And some people post them on Facebook. It's a really interesting post-privacy world. So to not sidestep your question, so I have a primary care provider at a CLSC in Quebec, so a community health center. I've actually had the same doctor there for 25 years. She's a salaried doctor. I see her very rarely, to be honest. I'm a boy. Why would I go to the doctor? Short of being dead. But, you know, I see her more in the grocery store than I do at the office. So she's a salaried doctor. She's great, and she's retiring. And I'm one of these people who I don't know if I'll get another doctor. So in Quebec, I've gotten myself on a list to get a new doctor. And I understand the wait list is something like 3 years.
Wow.
So hopefully, nothing should go wrong in the interim. My mother lived in Northern Ontario, where I was brought up. She had sort of a traditional family dog. So my mother had a number of health problems. People have probably heard me talk about her. My speeches, but my mom had COPD, so chronic obstructive pulmonary disease, and a number of things that go with that, like a bad heart and and arthritis with age, etc., and eventually dementia from her. She had many mini strokes because of her lung condition. So my mom had sort of the traditional family doc. I don't think her care wasn't great. It was sort of like, come in once a week and I give you 7 minutes and I won't look you in the eye. So I was never happy with her care, but lots of in and out of the emergency room as people with COPD happen. And she is of the generation that, of course, never complained, was just thankful that she had free health care because she didn't have it when she was young. I was born just before Medicare, in that my parents were in Quebec at the time. Quebec didn't get Medicare until '71, but they drove across the river to Ottawa. My mother would always say I was born at the Sally Ann Hospital. It's the Salvation Army, and she said, we got you at Sally Ann, and we can always send you back, so be careful. But they went there because they had no money, and it was free to give birth there. So always thankful to the Salvation Army, and I always put a little money in their kettle for that. So my mom's care was good, but her, she had many frustrations, as I think many Canadians do with her care. Just sort of how impersonal the care was. Going to the doctor, and the guy literally would never look her in the eye. I remember going to some appointments with her. It was so frustrating. And just get in, get out. And then in the emergency, asking her history over and over. She lived in a small town. They knew who she was, but she had a paper file like this thick that nobody ever looked at. So my mother took to turning off her hearing aid when she went to medical appointments. She found that was about just as useful. She said, they don't listen to me, I'm not going to listen to them. She would just nod a lot. So that gives you a sense of her care. And the sad, happy part of my mom's care came in the end when she got quite ill and she was in a nursing home. And because of her dementia, she was quote-unquote violent. She would hit nurses, she'd be scared. But my mother was a very tiny person. She was less than 5 feet tall. She's only about 80 pounds in her later years. So I have trouble thinking of her as a violent person. But anyhow, the upshot was she got kicked out of all these nursing homes and ended up living in a psychiatric hospital, which was in the process of being closed down. So she got fabulous care. She actually got one-on-one nursing care for the last 6 months of her life. They treated her really well. She was in her street clothes. It was actually fabulous care, but she was of the generation that her friends wouldn't visit her because she was in the OH, if you know the Ontario jargon, the Ontario hospital. And that was a taboo, go see the crazy people. And she really died very lonely, and that was, to me, the saddest part of her care. So it's a real trade-off, and again, it's sort of full circle. It brings me back to that St. Mike story about how the human contact is so much more important than the medicine. So sort of mixed feelings about her care. Sorry for the long, rambling story.
So where would you go if you could, choose, in all your travels, where is the place where you'd be most impressed with how they deliver primary care?
So I'll answer that in 2 ways. So I think technically, the medicine side, the access, etc., I think I'd go to the Netherlands. I think the Netherlands has fabulous primary care, so I know that I'd be attached to a clinic, that they would know me. I'd have a good medical record. I'd have efficient medical care. So if I was going for the technical, that's where I would go. I think the Netherlands, or if I was old, I'm not old yet, but if I was really old, I'd go to Denmark, because they have fabulous care for the aged. They have small homes, really home-like nursing homes, and I like that. And they have very little hospital care. They urge people to get a hospital. I'd hate to live my life out in a hospital in the final days. So I guess I'd go there. But the other part of the equation, the reality is I'll be here, I'm Canadian, and where I'd like to be is where I have family and friends, because I think that's essential in healthcare now. I don't think you can afford to be alone in our healthcare system, because that's dangerous. And that's unfortunate to say, but you really need advocates for you. So I would probably want to be back in my hometown in North Bay, because I have a younger brother there, and he could take care of me. He took good care of my mom, and I figure he could do that for me if he lives a little longer. So I think that's probably the route I'd go.
So the book is a compilation of many of your, I guess, favorite articles over the years, and you told me that you've gone some of the older ones, you've updated the stats, etc., to make sure that they're up to date. So I guess a two-pronged question for you: if there was one, how many stories are in there, or how many articles?
There's about 80 columns in there. Yeah.
So out of those 80 columns, if you could choose just one that a medical student or a nursing student or an OT student who is starting out, you think he or she should read, what would it be? And the same thing for a new minister of health who's never been involved in healthcare before, which is most of our ministers of health.
Okay, those are tough ones. I think maybe the med student,
And why, obviously.
I think I'd point them to sort of the introduction, where I tell that story about the patient, because I think that's really important to understand that what really matters ultimately is the human connection. So I think that's the most important lesson. When I get to speak to medical students, that's what I talk about. I often talk about my mom. You know, I talk about how I talk to her about, I like to use this anecdote about my mom. So I was reading a lot about privacy. Privacy legislation, a very high-end academic debate. So I thought I'd ask my mom about this. My mom's in the health system. What do you think about all this privacy legislation? And my mother was pretty gruff, and she said, "Privacy? Don't talk to me about privacy. These are people who put me in the emergency room hallway with my ass hanging out." That's what really matters to people, right? So I think that's what I would like to emphasize with students, is just remember, try and put yourself in the shoes or in the assless pajamas of your patients, right? And think through that lens, and you'll be okay. So I think that's what I tell. What would I tell ministers? One of my favorite pieces in the book is actually about a piece about the saga of building the Montreal Super Hospital. I think I'd maybe get them to read that, because that's the beginning of that story says it's a reminder that it took 21 years to build the Taj Mahal in India, one of the most glorious buildings in the world, 3 centuries ago. And then I go on to say it took longer to build a utilitarian hospital in downtown Montreal. So what that story is about, it's about the politicians losing sight of what's important. They fought about who owns the land, what it should be, how many beds, all this technical stuff. And in the end, people went 25 years without a new hospital that was needed, and everybody knew it was needed. So I think I would point them to that and say, listen, keep your eye on the ball. You don't have to get to, don't let perfect be the enemy of good. Get your work done, get stuff, the patients need today, and don't dick around to please your political friends.
You mentioned that you do a lot of public speaking, and I follow you on Twitter, and it's amazing where you are. So I guess a question around your favorite audience, and why, and is there an audience that you really wish they'd invited you, but you haven't gotten the invitation yet?
Well, of course, this is my favorite.
Well, yeah. He's smooth, eh?
No, I don't think, I think they're all different. I get to sometimes do like really little intimate small gatherings with, say, a bunch of PhD students. That's really interesting to interact, and then some big, surprisingly big audiences like this one. So I think it depends. I kind of enjoy the interaction. I think it's important to get out of the office and meet people, and I look forward to meeting more people after. So I think that's what's important to me. Where have I not been invited? The Bob Dylan wouldn't go to the Nobel Prize in Sweden, but I won't say no. I love Sweden, it's a lovely country. But no, I can't think of a place offhand that...
But in your book, you actually talk about, one way of looking at a two-tailed healthcare system is not around the finances, but actually you talk about the urban-rural split in terms of the issues for healthcare. And then you've got a whole chapter on Aboriginal First Nations kind of research. Have you had the opportunity to do these kinds of sessions in those communities?
I do get around a little bit, so I go back to, I've done some stuff up in my hometown in North Bay, not exactly rural, but it's hard to get out to those places because there's no money for them to bring you in, and the venues are not there, but I try and sort of squeeze them into my travels. I think that, you mentioned the Indigenous health. I think to me that's the single most important political and health issue in Canada by far, is resolving that. And I think it's really important now because I think there's an opportunity there. There's a willingness on the part of the government to talk about this and act. There's the discussion of reconciliation, I think, is really key. We're not going to have reconciliation unless we deal with Indigenous health. It's really there's several essays in the book about Indigenous health. One of them is called It's Our National Shame, and it is the state of Indigenous healthcare. But I've learned over the years to not be, I hope I've learned to not be too negative. Because I think you have to realize, and I do have the privilege of traveling around, and you soon realize that there's a lot of really healthy Indigenous communities, right? It's like everything else in the world. There's disparities within the communities. So to me, that what we have to stop doing is going into these communities as experts from the outside and trying to fix them. What we have to do is allow these communities to interact and learn from each other. So I was in Saskatchewan not too long ago, in a community, an Indigenous community, Treaty 4, fabulous healthcare, great healthy community. And I was thinking, I was talking to them, I was like, why don't you guys go to Attawapaskat and help them figure out how to fix it instead of, I was just at a wonderful speech by Alika Lafontaine, a great young doctor and leader who won a public policy forum award. And he talks about this, about how, we send in these outside experts and they just kind of whisper among each other and they fix things and they don't get fixed. And he said, just listen to people in the community, help them out, and they can fix things themselves if given the opportunity. We don't create those opportunities.
Is it okay if I have another 5 minutes and then open up? Okay. So I guess I would say you have a lot of influence in a lot of ways across the country. So, and I would say with that influence comes responsibility. So is there an article that you haven't written that you kind of really wish you had, or a major topic that you wish you covered? And is there an article that you look at or an area that you look at and think, geez, I wish I'd done that a little differently?
I think it's the nature of the beast is that it's just sort of a continual process. We never get it done, right? Yeah. So I do little snapshots day to day, and I never do the motion picture. So that's the frustration, right? So yeah, there's 1,000 things I wish I had written about, and hopefully I'll be around a little bit longer to tackle some of them. One of the most interesting things about putting the book together for me was that realization. And I was talking to somebody about this morning, and always, you realize, geez, I haven't written about cancer for a while. Like I have a whole chapter on cancer. I realized, geez, in the 90s I wrote about cancer every second day. Now I kind of take it for granted like everybody else. So I think, I'm going to get back and do some cancer stories. When I was putting it together, I was like, geez, I didn't write a lot about heart disease. I don't know why. I've been to many Canadian cardiovascular congresses. I touch on it, but I don't know. So things like that I go. I wish that, there's a chapter on social determinants of health, which is something I write about a lot now. I wish I had written about that 20 years earlier, because I think that's really impactful. It's starting to enter the mainstream discussion. This notion, well, it's not a notion. We know clearly that the most important things for our health are our income and housing and education. A sense of belonging is one that's really important that I've talked about to our health. And that's really a lot more important than medicine. Medicine is trying to fix people after they're broken. This is about keeping people healthy in the first place. So I write more and more about that. And I write about, I think what distinguishes me is I write about policy as opposed to medicine. Right. Lots of people write about, now it's medicine, but I think policy people think it's boring, and often it is, but without the policy, none of the good medicine can happen, or we create impediments to good medicine.
So 2 final questions. So most people would say that health matters more than wealth. So why are there more business reporters at the Globe than there are healthcare reporters?
Because I think because money runs our society, right? And because that's our demographic too. Every paper is going to have its specialty, but I think more and more we are covering healthcare more in the business section, to be honest. And I think that's important. I wrote my column this week is about vaccination, and it was based on a report by the C.D. Howe Institute. And people are like, what business does C.D. Howe Institute have writing about vaccination? And I say, that's great. They write about for every dollar spent on vaccination, you save $16 in health costs down the road. They see the business argument. What has advanced the mental health discussion in this country? It's changed dramatically in the last few years. A lot of that is driven by business. This recognition that the number one cost of disability in long-term and short-term in Canada is mental health. And when at our paper, we're a business paper, where a business has to make a profit, and we pitch our stories. I want to do a big project on this, and years back we pitched this big series on mental health. And the Globe did it, because they thought it was important socially, but they also saw the business case for it. Right? This matters to our readers, it matters to our business readers, so therefore we're going to invest in this. And it is an investment. We did 24 full pages in the newspaper. That's millions of dollars in business-wise. So I think that business case is really important. When you gave my little bio at the beginning, you didn't talk about my secret that I actually have a business degree. I studied in accounting. I don't have any science background, and people are always shocked by that. But I think that business argument is really important. And this notion that people think that all businessmen are a bunch of right-wing, selfish people, and it's not true. A lot of them recognize it's probably easier to make the social determinants of health argument in a business audience than it is in a medical audience, oddly enough. Because I've had the experience of doing both, and they go, yeah, I see that. I see education, yeah, we invest in that. Housing, absolutely. People understand that. And I write in the book, the single most powerful drug we have in society is money. Now the problem is it's not prescribed very well, right? Some people have a lot too much of it, and many people have too little. So when I talk about things like that, people laugh, but it's a reminder that things like tax policy is really important to our health. Again, it's what's more boring than income tax, but it's really important to people's health, can make a difference.
Certain times of year that I don't think income tax is that boring, but.
May 1st, around.
Sorry. Yeah. So the final question. So I graduated from Queen's Med School in 1979. And I would say, in all honesty, that I've seen the way and I think many of my colleagues think about the healthcare system as having gone from kind of being, I think 40 years ago, internationally one of the shining lights, to now actually doing quite poorly on almost every international sort of metric you can have. And that's kind of depressing, to be honest. And in preparation for the question, I actually asked a few people, like, what do you think I should ask Andre? And I asked a few patients. And it was interesting to me that a number of the patients actually sort of said, like, how does he have hope when he's writing about all the problems in the healthcare system? And actually, they were, in all seriousness, they were asking from themselves about, like, how do we have hope about our system, which we honestly don't think is as good as it should be or others have shown it can be. So what would your answer to that be?
Yes, I'm glad we have 30 minutes left.
Yeah.
So yeah, I am unusual in that I'm a journalist who's hopeful, not totally cynical yet. But I'll tell you what gives me hope is a couple of things. One is I think we have, and I know this more from my parents and from talking to patients than from reading fancy journals, I know that we have excellent medical care. So when you're in the right place at the right time in Canada, the care is second to none. You get as good a care as anywhere in the world. So that's really important. And I also know that every single problem we have, and we have lots, we have the single worst access in the world. That's one of the most troubling things these days. Of all the problems we have, I know that every one of them we've resolved, and we've resolved it at least 10 times. And the issue we have in Canada is scaling up our successes. we have all these pilot projects, we solve problems, and then we defund the pilot project. So I know that it can be fixed. That's, I think, the number one reason I'm hopeful. And I had one other brilliant things to say, and it's just slipped from my mind. But yeah.
But people have been pointing out that we have this pilot problem for like 10 to 15 years.
Yeah.
And I don't know about you, but I don't see us getting any better at fixing it. So do you have a thought about how we do that?
Well, you know, I think ultimately what it comes down to is that we don't have medical problems in our system, right? What we have is engineering problems and administrative problems. And what we keep doing is we keep pumping more money into medicine. And we keep doing the same things wrong over and over. And Einstein had a very good expression for that. He said, doing the same thing over and over again and expecting different results is the definition of insanity, right? And there's a lot of insanity in our system. So I think we have to value the administration more. I know that's not a popular thing to say, bureaucrats are evil, but I think we have to get good bureaucrats, and to do that we have to give them power and we have to pay them decently, etc. And then we have to get the engineering right. To me, as I said, and I learned this a lot from my mom, excellent care here, but boy, the journey in between, full of potholes and cracks. Everything bad that happens in healthcare happens in transitions. So we have to get the transitions right. We have to have more navigation. We have to have more organization. We have to stop having these false walls that we build all over the country. You know, I read about vaccination this week. It's a perfect example of, in this country we have 14 different vaccination schedules for children. There's absolutely no excuse for that. We need one. I can print you one off the internet. Let's sit in a room and take 5 minutes and agree on this. And we've been talking about this for 16 years. And that's the number one problem in Canada, is we just don't do stuff that we know we should do. And that takes leadership, and that takes good administration, and it takes a plan. One of my big frustrations with Medicare is, you know, people often ask me, do we spend enough money on healthcare? That's probably the first question I'll get from people. And my answer is always the same. I don't have the slightest idea, because I don't know what we're supposed to be doing. What is the mission statement of Canadian Medicare? Many years ago, I went to visit a company, a device maker. I won't name them, but they had a plaque on the wall with their mission statement carved in bronze. And it was very simple, you know, our mission is to make the lives of patients better. And I was like, geez, what's the mission statement of Medicare? The mission statement of Medicare is, let's spend as much money as last year, and maybe a little bit more, and not getting too much shit with our bosses. That's not a mission statement.
So, Mr. Non-Cynical, we're now going to open it to the audience for questions. This auditorium, if you're sitting down near the front, it's very hard to hear questions at the back, so we are going to have to use, I think we have microphones on each side. So, hands up who want to ask André a question. Yes, right in the front here. Oh, okay, we'll go there and then the front down here. And could you just briefly introduce yourself, and we'll try and make the questions brief and the answers as well.
Hi, I'm Amy Stewart. I work with Ontario MD and the University Province. So I'm curious because you talked about administrative and engineering challenges. And sometimes one of the approaches conflict, I think. So one of them is you let each region decide what they're going to do, and then they customize what they're going to do to solve the problem. Another way is to impose a solution on all the regions, but that might fail in a different way. So I'm wondering kind of how to address that challenge. What do you think is the better way to address that challenge?
Great. So I'm not an expert in system design, but I think that the principles that I've heard about and that I've written about is I think you have to have rules, but I think there has to be some flexibility. So Canada's a big country, the regions are different, there are different needs from even within the province. So I think you have to allow that flexibility, but I think it's about standards. We're going to meet this minimum standard, and the problem I find is that we have these standards, and what we get is, to use a mathematical term, we get sort of a regression to the mean. So we get everyone aiming to be mediocre so they don't stand out, as opposed to having a system where Let's have one of these regions excel and then expect the others to catch up to them. So we have to find a way of incentivizing better administration. So I don't know exactly how to do that, but I know that many other countries do it, and the lessons are there to be learned from. So I think it's a mixture. It should be ultimately the Canadian approach, being pragmatic and doing a little bit of central control and a little bit of local control. So I think it's doable. And again, there are some regions that operate really well. I know people are not big fans of LHINs for a variety of reasons, but to me there's some superb LHINs and there's some terrible ones. And we should be, instead of crapping all over the notion, we should be looking at the ones who work well and making everyone else work as well.
Hi, my name is Julia. I'm the founder of .health. We are a personal data platform. Given that we have a public healthcare system, sometimes bureaucrats and people in positions of power have this 30,000-foot view of the entire thing. So it's very top-down. How do you see, and you sort of alluded to the intersection of business and health, how do you see almost a bottom-up economy happening in Canada at the intersection of business and health? Because I think we often feel like that doesn't exist or it's not possible because we're a public healthcare system. And I'd love to know the areas that you see that are totally ripe for innovation from the private sector.
Yeah, so the areas ripe for innovation are pretty well all of them, so there's no limitations there. But I think the question you ask is a really important one. So people wonder that. Can you have, can patients have influence in a public system? Because we kind of think, oh, well, there's a market, you speak with your money, you speak with your feet. So how do you integrate that into the public system? And I think it's a really tough question, but again, I look to other countries. I don't look to the US because I think they're an outlier, but if you look to European countries, how do they do it? And I think what they do is they integrate the patient voice into the administration. And that's not just about having a token person on your board of directors of the hospital. We do a lot of that in Canada. Everybody around the table is paid except the patient, who's a volunteer, who's cowed into doing whatever the others are doing. So I think you have to have real power of patients. They have an equal vote and they have a say. So I think it's getting them integrated into the administration, but in a way that's fair. So you pay them for your time, etc. And that's what I see. So I don't think that the fact that we have a largely publicly funded system is an impediment to innovation, because it's happening everywhere. But again, it's about choosing. We have to choose priority areas and work on them. So, what's Canada known for around the world is known for wait times, unfortunately. So I think that has to really be a focus. There's a lot of interesting writing going on about waits in Canada, but there's not a lot of interesting action taking place about wait times. So I think that's what, if I had to choose today, I would pick as a focus. I go to a lot of these hacking health things. Fabulous ideas again, and again, we talk about them for a weekend, and I don't really see them implemented. So again, they have to be a willingness to change. Thanks.
Questions?
This is sort of a...
Do you want to just briefly introduce yourself?
Oh yeah, I forgot about that, sorry. I'm Kathy Kastner, and I'm a health blogger in the end-of-life space. I talk about dying and death all the time. I'm so much fun to party. I've just come from a health literacy conference where a palliative care physician said health literacy is not a patient's problem, it is a healthcare professional's problem. Andre, could I task you with getting the policy changed so that all healthcare professionals have to learn how to speak our language? Can I do that? Can you do that for us?
Yeah, well, I think everybody in this room can do their part. So I think we're actually getting better at that. I think health, there's a recognition that people have to understand what you're saying. I gave the example of my mum's care. I think that was a classic example of how not to do it. Just a bunch of gibberish. It was right for my mum to turn off her hearing aid because she wasn't getting any useful information. So I think, I talk again when I get to talk to medical students, I tell them, and I'm doing a convocation address at U of T, and I'm going to talk about this, that, what's the single most important thing you can say to a patient? And it's, hi, how are you? It's not very complicated. It's not blah, 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 your blood pressure. How are you? And then, the even more important thing is to actually listen to them when they answer. not to just do it as a rote action. Oh, I learned this in medical school. I'm supposed to say, hi, how are you? Check. And then I'm going to go back to talking about gibberish. So I think it's this really old-fashioned conversation is so important. And patients, well, you know this, Kathy, is patients know when you're bullshitting them. They know within 5 seconds. My mom would know when she wasn't being listened to, and she stopped talking. So we have to value that. And again, I'm not blaming healthcare workers. We get the results that we build a system for. And the system says, you're only going to break even if you have your patient in and out of here in 7 minutes and you deal with one issue. We have to fix that. We have to pay practitioners differently if we want different results.
Thank you.
So, yep.
Good morning, André. Todd Alvin, Health Group. I was doing some research recently, and I should say, I ran hospitals as president for 20 years, private practice now. But anyway, the one thing I found consistently, maybe you have an answer for this, maybe, or sent articles about it. But what I found in my whole career, that we have tremendous untapped resource in our facilities. That is the employees of our facilities. We have over 1 million people plus employed in healthcare related services across Canada. I feel that we're missing a golden opportunity to solve a lot of problems by much more staff involvement. I'm talking about getting into departments and asking them, is your department the best in this city? Is it the best in the province? If not, why not? When I ask that question, I never get an answer saying, yes, we are the best. And I'm saying, why is that? Why can't we bring together our staff teams more than ever before and start tapping their great potential, which they have so much? I work a lot with groups of staff over a number of years, and I've never been able to have them identify a problem they can't solve in about 15 minutes. Just the new dynamics. And I wonder, André, if you could promote that sort of philosophy. We have to start looking at the people that care for your mother in the hospital, that care for people that do the jobs that we have to do in hospitals, the food service, all of the different departments and so on. I don't think we give enough respect to our general staff and use their brains, which are the same brains that we have. They're no different. We just have to give them a challenge and let them run with it and support them. So I wonder if you care to comment on that, and whether that's something you could address in the future, maybe in future articles, of course.
Yeah, that's an excellent point, and I think you're right that people who work in a system know the solutions, right? They know what the problems are and they know what the solutions are. And the issue is, how do you give them a voice and not crush them? So I wrote recently about a nurse in Saskatchewan who complained about healthcare. What happened to her? She got prosecuted by her own profession, fined $26,000. That's the antithesis of what we should be doing, right? So I think there has to be a way of integrating the staff into that. And I remember this, I don't remember the details of this, but there was an excellent example of, I think it was in a Calgary hospital, where they were having this problem where, I forget, some kind of tubing was always leaking, and it was solved by the janitor. So the janitor would go in, because this tube leaked all the time, he had to go in and mop it up every day. And one day, the doctor actually talked to the janitor, said, geez, I'm sorry about this, that you have to come in here and mop this up every day. And the guy goes, yeah, if you put a hook on the wall and put it there, it wouldn't leak. And everybody went, wow, we'll spend 59 cents. And he didn't have to mop up every day. And because of that, the doctor actually started doing rounds with the staff, and he invited everyone, janitorial staff, the food people. They solved about 15 things in the first week. So you're right, there's a real untapped resource there. But again, it's about building a system that lends itself to that. To me, I always write that healthcare is profoundly undemocratic. And that's a real example. We don't give people a voice within the system, and especially we don't give patients much of a voice. So we have to work on that and making it more democratic.
Andre, when I've done Faces of Healthcare, where I interview either patients or providers about, and sort of say, tell me your story, and I have an agreement with them always that they will get to see what goes up on the site before it goes up. And I'm always sort of saddened by a few times when patients sort of say, you know what, I just don't, actually, when I look at it now, I just don't want to say that publicly because I'm afraid it's going to piss off my provider and I'm actually not going to get the care I think I should get. And, you know, this week we posted an interview with an Emerge doc that I got an amazing amount of emails from in a very positive way. And if I distill what the gist of the emails was, it was, my God, she was honest. Like, that's literally what people are saying. I can't believe she actually had, and so, can you talk a bit about why is it that we're not, what is it about our culture in healthcare that makes us afraid to speak up, at least in my opinion?
Yeah, I always see that, and I get that same fear when I interview people. They're like, oh, I don't want to offend my doctor, maybe he'll start treating me, or I don't want to offend my hospital because they're good to me, other than the 19-hour wait, etc. So I don't know, I think it's sort of part of the Canadian way of, you know, we don't want to rock the boat too much. I don't get it.
And there's probably only one provider, too,
Yeah,
right?
often, yeah. So again, I got that with my mom. I remember my mom once going home for a weekend to visit her, and she was very groggy and confused, and she was all bruised because she had COPD. She took all these anticoagulants, so she bruised easily, but really looked like she'd been beat up. And I was like, geez, what's going on? And I went to her medicine cabinet, and I'm not a physician by any stretch of the imagination, but I just sort of Googled the stuff, right? Here's her 16 drugs that I found in the medicine cabinet. I found these really obvious, you know, contraindications. And she happened to be going to the doctor the next day, so I was like, I'm going to the doctor with you. I'm pissed off. And she's like, oh, geez, you know, if you complain, he might not see me again. And I'm like, oh, bullshit, like, what's going on there? And I lined up these drugs, and I said, I'm pretty obnoxious, unlike my mom. And I said, listen, we've got 16 here. I think we're going to leave here with 2 or 3. And he was like, oh, you know, that's not possible, and I'm busy. And I said, I have all the time in the world. You know, take all the time you like. And he's like, oh, he sort of rolled his eyes, and he said, garbage, garbage, garbage. And we left there with 3 drugs. The next day, my mom felt great, you know. But it's just little things like that we don't do follow-up. And then I proceeded to tell him about a story I'd written about a pilot project where they send pharmacists into people's homes like my mom, and they do what I did. They clean out the medicine cabinet. Because she had, 5 drugs from 5 different doctors, or this guy's locums or whatever, didn't bother reading the record, et cetera, et cetera. So all kinds of ways we can do stuff more sensibly that doesn't cost money. And, did it take 5 minutes more of his time? Yes, but it probably saved him 4 appointments, but we don't tend to think in those ways.
All right, other questions? You got one there, and then we have one someone down the bottom here.
My name is Oliver Johnson, and I work with Big Pharma. So the Ontario government just recently, announced that it's going to be providing Pharmacare to people under the age of 25 in the province. Can you sit in your thoughts around the future of Pharmacare within this province as well as the country? And any thoughts around if you were to be speaking with a new health minister, or the health ministers, what key principles should be mentioned in that?
Yes, so Pharmacare, an issue that I write about a lot. I wrote recently about I call it Kitty Pharmacare. So I think an interesting political gambit, I think health-wise, semi-useful, providing drugs to probably the demographic that least needs them. Wouldn't be my priority if I had power. But I think the issue to me with Pharmacare is that it's essentially the unfinished business of Medicare, right? If our philosophy is that people should get essential care without the impediment of cost, then it has to extend to drugs. I think that's logical. But the question then becomes, how do you do it? And I don't think there's any one way. Quebec is the only province now that has a universal Pharmacare program. It's done with a mixed private-public model. So I'm employed, so my employer must provide me with drug insurance. If I couldn't afford it, then I could buy from the public plan. So that's one approach. I think if we're going to have Pharmacare, we have to, it doesn't mean all drugs to all people at all times. It means essential drugs. It means having probably a fairly strict formulary. But again, this has been done by 50 or 60 countries in the world. It's not we don't have to think too hard to do it, but we have to do it. So to me, again, we have to figure out what the purpose of Medicare is, and we have to fix our system. The converse of that is I don't think that all care provided by doctors is essential, or that all hospital care is essential. So maybe we should have some private element in that, or if not a private element, some limitations. So we have this weird bifurcated system where we cover 100% of drugs and of physicians and hospitals, regardless of their value or utility. And then other stuff, we only cover about 4% of dental care in Canada. Again, European countries, dental care, the mouth is actually part of the body when it comes to providing health care, right? And so is home care, so is long-term care, so are drugs, but there are limitations on them. So I think we have to just catch up and modernize our system. It's not wrong, but it's just not up to date. I think we're trying to deliver 21st century care with a 1950s model of insurance, and we have to buff it up.
Question here?
Hello. My name is Laura Jenkins. I'm a patient advocate and navigator. You said earlier that you often get asked whether there's too much or too little money spent on healthcare, and it's difficult to answer that because there's no mission to compare against. So I'm just wondering, based on your 30 years of patient stories and health journalism, what do you think people want the mission to be?
Can you repeat that? Because I have a feeling you got that back.
Yeah, so the question is, what do I think the public thinks the mission of Medicare should be? And I think it's what I just said. It's to provide essential care to everyone, regardless of ability to pay. Oh.
Sorry, could you just expand on essential?
Well, yes.
Fire a little issue.
Yeah, so I think and I was just going to add that, but it's not difficult. It's not easy to define essential. But I think most of essential we can agree on, but then around the periphery it becomes difficult. So I think essential has to be a moving definition. So the question to me becomes, how do we decide? Let's all agree, if you have a heart attack, you have cancer, you're going to get treated. But does that include getting this new $1 million drug? Well, I don't know. So the question becomes, how do you make those decisions? And the way we make those decisions now is by the seat of our pants. We kind of say, we'll say no until there's a story on the front page of the Toronto Star, and then we'll say maybe to that person. So to me, what's lacking there is a process. So how do you decide what's covered and not? And I think there has to be a more formal way of doing that than this reactionary political intervention. I think we have too much micromanagement by politicians in our country. So I look to places like France and the Netherlands. So what do? They have formularies for drugs, and they're constantly being revised. But they're really public about, we're having a discussion of this new cancer drug, and we're going to decide, is it covered or not, and for whom. Now, we do that in Canada. We have CADATH, we have the Common Drug Review, but it's not quite as public as it should be, and the process isn't as open. I like FDA hearings where the patients go testify, for example. So I think we have to do that stuff a little faster and a little more publicly. But it's never going to be easy to decide what's essential, but it's essential that we do. So.
Hey there, Melissa Foster with Global Public Affairs. More and more we're seeing patients being brought to the table to have a say in the development of public policy, whether provincially or nationally. And oftentimes it's one patient. I think that there's a bit of a misconception that there is a singular patient voice out there on almost every health policy issue. I'm just curious if you have any insight or ideas into how they begin to incorporate a broader patient voice or patient voices in that conversation, or begin to find a little bit more consensus, if possible, amongst the patient population or the general public on some of these key health policy issues, Pharmacare being, I think, one big one right now.
Yeah, I think you make a really good point that there isn't just one patient voice, there are many. I think one way to incorporate them to me is to try and level the playing field. So I mentioned in passing before, you can't have a meeting where everybody at the table is paid except the patient, who's supposed to, has to be a volunteer. I think we have to recognize that patients often can't give input. They're busy, being sick, getting well. So I think we have to integrate that. I think we have to not put all the pressure for patient-centered care on patients. It has to be integrated into the provider point of view. It shouldn't be a adversarial notion. It should be, listen, this is best for my patients. And I think, again, to be fair, there's a lot of that. So I think it really depends. It's hard to answer your question because it's a large one. It depends on the context, what we're discussing. But if you take your example, what should Pharmacare be? I think there's a real role for patients there to talk in sort of a public hearings aspect, commissions. In Canada, we've discussed a lot about end-of-life care and assisted dying in recent years. And there's been some really good panels who I think have been exemplary in including the patient voice in there, getting people with lived experience and people whose spouses have gone through horrible experiences and really being equal members of these committees. I think that's the way to go as much as we can.
So, Matthew told me that when he comes down to the front and crosses his arms, it's time to wrap it up. So you didn't say you were going to clap, so it's time to wrap it up. So thank you very much.
Is available out front. I believe it is $25 flat, and I'm sure we can convince him to stick around and sign a few books. Our next breakfast with the Chiefs is with John Daniels, Global Health Affairs Executive Vice President for HIMSS Analytics, and that'll be on June 22nd. Thank you. Have a good morning.